Well, good morning, everyone, and welcome to this kickoff webinar for It's Healthy to Fight Modern Slavery. I'm really excited to be with you this morning. My name's James Cockayne. I'm the New South Wales Anti-Slavery Commissioner. My role is that of an independent statutory officer, so I report to the New South Wales Parliament, not to the New South Wales Government. I'm tasked with, among several other responsibilities, helping to mobilise the New South Wales Government to better identify and support people who are experiencing or have experienced modern slavery. I'd like to extend a particularly warm welcome to colleagues from the healthcare sector joining us today, for whom this may be a first introduction to modern slavery issues potentially. Thank you so much for coming. This is a conversation we've been looking forward to for some time. I promise we'll keep the anti-slavery acronyms and jargon to a minimum today. I'd like to start by acknowledging that I'm joining you today from the unceded land of the Wonnarua Nation and pay my respects to elders past and present, and extend that respect to any Aboriginal colleagues joining this webinar. In acknowledging country at the beginning of a discussion about health and modern slavery in Australia, we think it's important to acknowledge that First Nations Australians today live with the legacies of practices that would today constitute modern slavery, including forced labour, servitude, and in some cases enslavement. Those practices live in their bodies, both as direct survivors and as descendants of survivors. There's a documented history of practices wrought here in New South Wales on Black bodies that today would constitute modern slavery. And we know that this trauma is passed down intergenerationally. Through 5 or more generations, the trauma of slavery has been shown through effective social science overseas to produce negative health and human development outcomes. And people in our New South Wales community continue to live with this legacy every day. Now, today we have an exciting group of international and New South Wales speakers joining us who've worked in a diverse range of healthcare settings and anti-slavery programs. Following some opening remarks from Dr. Joe McGirr MP, the chair of the New South Wales Modern Slavery Committee in New South Wales Parliament, the webinar will be structured in 4 parts. First, we'll look at what is modern slavery and why it's a health issue here in New South Wales. We'll then welcome international guests from Heal Trafficking to provide an overview of how healthcare can be a powerful tool in the fight against modern slavery. Then we're going to drill down to what this means for New South Wales healthcare practitioners. And finally, we'll tell you about how you can get involved in the It's Healthy to Fight Modern Slavery project. Well, we should have just a little bit of time for questions if all of our speakers stick to plan at the end of the webinar. So please send your questions to us through the Q&A function that you see on your screen, and we'll do our best to get to as many as we can. We are recording this webinar and we'll share a link following the event. Please do feel free to share it with your colleagues who are not able to join us live. So to get us started, I'm really delighted to welcome Dr. Joe McGirr, MP. Joe is with us through my phone. We just had a couple of last-minute technical glitches, so unfortunately he won't be on screen, but you'll be able to hear him through my phone. Joe is the member for Wagga Wagga in New South Wales Parliament and serves as the chair of the Modern Slavery Committee, the only such standing parliamentary committee on modern slavery in the world. Before entering politics, Dr. McGirr worked in regional New South Wales for more than 30 years, firstly in emergency medicine, then in health and hospital management, followed by a time in university administration. So I really appreciate Dr. McGirr taking the time to be with us on a busy parliamentary sitting day, and I'm looking forward to hearing his interesting perspective as both a medical professional and an anti-slavery advocate. Welcome, Dr. McGirr.
James, thanks for that introduction, and more importantly for your work and the work of your team in the crucial fight against modern slavery. I also would like to acknowledge the traditional custodians of the lands that I meet on, the Gadigal people, the Eora Nation here in Parliament, and of course for my electorate, the Wiradjuri people. As a medical doctor, I've been privileged to work with great many minds and big hearts who've been committed to helping their fellow human beings. And now as chair of the New South Wales Parliament's Modern Slavery Committee, I'm learning of many more great minds and big hearts all united in tackling the scourge of human trafficking and exploitation. And I welcome today champions of that cause, including Dr. Amanda Stylianu and Dr. Honey Stocklosa from the US-based Heal Trafficking. And I also acknowledged Dr. Jamie Burrows, an emergency physician at the Royal Prince Alfred Bankstown Hospitals, who's been at the forefront of anti-slavery work. I also welcome Sarah from the Office of the Anti-Slavery Commission to gain her insights into the issue as a lived experience practice leader, and also welcome Corinne Baker, who will be helping us later today understand how we can get involved. The combined wisdom and experience of those experts today will be great to listen to and will help us in our efforts to erode modern slavery in all its forms. The challenge clearly cannot be understated. It's frightening to think there are at least 40 million people around the world in modern slavery, and in New South Wales alone, as many as 16,000. It's not a problem confined to the past or to poor countries. People live in modern slavery among the wealthy nations. Thousands of people in forced labour or forced marriage, forms of financial bondage and sexual servitude, to name just a few of the issues that we're facing. And we know that people in that scenario will suffer both physically and mentally, will have shorter life expectancy, and there is a risk of passing on trauma to future generations. And so I'm very happy to be here launching this initiative. It's healthy to fight modern slavery. Now, of course, it's healthy to fight modern slavery because we want to improve the care and the health of victim survivors. But there are two other aspects of this I just want to touch on. The first one is that because those who experience modern slavery may present to our health services with the effects of modern slavery, if we are not aware of that as an issue, we may not recognise the root causes of their ailments. And so everyday caregivers in emergency departments or clinics, or service providers delivering help to mothers and children, refugees or the homeless may well come into contact with people who are suffering the effects of modern slavery. But because people don't speak about it and because we're not aware, there's a risk that we won't pick that up, and that will affect the opportunities we have to provide health care. So it's important that we do provide the right training and knowledge so that people are best equipped to detect this exploitation in people who may be their patients. We know our healthcare workers at the front of restoring health to everyone, and this is an important area. But the second aspect that it's healthy, that where health comes into this, is in terms of unrecognised need. And in my electorate, for example, this surfaced in an issue with the partners of overseas workers in some of our farms, their partners not presenting for maternity care when they were pregnant because they were afraid of cost and afraid of stigma. And so not only do we need to, and I'm sorry about the bells in the background, not only do we need to, I think, focus on skilling up our health workforce, but more generally, we need to make sure that people recognise that there is not a stigma attached to this and that healthcare is available. In the particular issue that I was involved with, there was a real risk that women who may have suffered complications in pregnancy, such as diabetes, did not seek care that could have made a real difference to their care and the care of their unborn and soon-to-be-born children because of stigma and fear of cost and essentially the circumstances they were in. So there are a couple of reflections from me. Once again, I welcome you all and particularly thank our presenters. And I just note that there can be few more noble causes, and that's why I'm very passionate about this. And I think we're on the cusp of harnessing a new force in the battle. And I'm excited to think how healthcare as a powerful good can change lives here in our community that will make a real difference. Thank you very much.
Thank you so much, Dr. McGurr, for those really insightful remarks and for demonstrating through your presence with us on a busy sitting day how fortunate we are to have you and all the members of the Modern Slavery Committee committed to driving anti-slavery action in New South Wales. So please don't linger if you need to go off and vote in Parliament or for any other reason, but we greatly appreciate your presence here today and look forward to continuing to work with you on this and related matters.
Thank you, James. And
thank you. So as Dr. McGurr touched on, modern slavery is a significant health issue, both for the people living through it and for the communities and health system in New South Wales more broadly. So to tell us more about this, I'd like to introduce my colleague, Sarah, who brings a truly unique perspective to the intersection between healthcare and modern slavery, and I think is really having an incredible impact on our work more broadly to fight modern slavery in New South Wales and indeed across Australia. Prior to her own experience of modern slavery, Sarah had qualified as a nurse, working in critical care roles in emergency and intensive care in a number of different contexts around Australia. On escaping her situation of exploitation in 2020, she returned to emergency nursing in Sydney for 2 years before I managed to convince her to come and work with us at the office of the Anti-Slavery Commissioner, then a brand new startup, so another sign of Sarah's bravery. She's now our lived experience practice lead. We're incredibly lucky to have Sarah involved in this work. Understanding the realities of being both a survivor of modern slavery and a healthcare worker, she's passionate about educating her fellow healthcare workers so they can better support people who may be at risk of experiencing or recovering from situations of modern slavery. Sarah, over to you.
I think as I continue our journey through this, what is modern slavery, part of our presentation, the important part for me about this is really that it took me quite some time to wrap my head around what modern slavery was, and the fact that I had ended up as one of the around 50 million people that Dr. Joe McGurr referred to earlier, that were experiencing modern slavery in the world, but also we believe that 41,000 of those people are here in Australia. I had never even heard the term modern slavery when I was actually experiencing it. And if we go to previous reporting patterns and population data, we estimate that that means that about 16,400 people are living in modern slavery here in New South Wales. So definitely, probably a lot more than what I ever would have imagined. And that's more than 16,000 people living as if they're owned by another person, because that's what modern slavery in its simplest form is. I'd experienced abuse before and violence, but this was really different. It took every part of my being from me. And although it's no longer legal for one person to own another person, the crimes that we put under this umbrella of modern slavery all have that one thing in common, that there's this concept of ownership. Just going through a few of the different types, this is a really broad crime type, I would say. In New South Wales, we have several offences that are considered to come under the modern slavery offences. There are a variety of different international definitions that are sometimes used, both from legal and humanitarian perspectives, and that can be really confusing. So I think one of the simplest way for me and many others to understand this is that it's when someone is subjected to abuse that basically uses force, fraud or deception and coercion to exploit someone for personal and financial gain. And we've heard directly from dozens of people here in New South Wales who've experienced these things, and have heard from many more indirectly. We've heard from temporary migrant workers who've been deceptively recruited into debt bondage situations in the horticulture sector, or Australian women that have been trafficked and held in sexual servitude in the commercial sex industry. We've heard from people with disabilities who've been trapped into domestic servitude or exploited in segregated workplaces. And then another big part of this is children that are sexually exploited online. We also have heard from newly arrived migrants and refugees who may have been subjected to modern slavery overseas and are still struggling with the legacies of sexual slavery and servitude that they may have experienced in war zones. And of course, Australian children who have also survived forced marriages or attempts for them to be forced to marry someone overseas. In fact, forced marriage is actually one of the most commonly reported forms of modern slavery to the Australian Federal Police. But I think the big question for all of us here today is what does that mean for us? And as James highlighted, I'm so passionate about the healthcare response to this because I have been on both sides of the fence, in the sense that I presented to healthcare services during the time that I was being exploited. And unfortunately, the healthcare workers were not able to recognise the situation I was in to help me. And also when I was a healthcare worker, I never received any training about modern slavery. And in fact, I still hear from healthcare colleagues that this is an issue that they often think doesn't really affect us here in Australia, and they aren't really sure what it would look like. So I wanted to run through a few clinical scenarios that might help us just kind of understand what it might look like for us here in our healthcare context. The first little scenario I'll run through is one that's close to my heart from emergency department setting. We had a woman that was brought into a resuscitation bay. There was a male person that was accompanying her, but he waited out in the car. The patient had sort of a fluctuating level of consciousness, and there was a friend with her that was quite anxious and teary, but couldn't give much information about what was happening, and just said that she'd taken some pills. One of the interesting aspects of this scenario was that the Medicare card that the woman presented with and the name on that card didn't match the name that the friend gave. So just in that scenario, I just want to pull out a few different things. Obviously, in healthcare, in emergency departments, we might think, oh, this is a drug-affected person, they were partying too hard with their friends. But there are a few things here that would potentially flag something a little bit different. One being that there was that male person accompanying her that waited outside in the car and didn't leave. The fact that this friend was quite anxious and wasn't able to really tell anyone what was going on, and this aspect that the Medicare card that she presented with had expired and that the names didn't match, which is quite an unusual thing to come across in our healthcare settings. So a few things that I want us to sort of think about as we continue to learn more about this issue, but something that may have presented as quite simple, but may have some red flags around a situation of modern slavery. Another little scenario that we came across was in a sexual health clinic where someone actually presented with difficulty breathing and weight loss, and was found to have untreated tuberculosis. They hadn't been able to engage with medical treatment for over a year and said that they couldn't afford the medications that they'd previously been given. There was a significant language barrier, and there was an issue where we then discovered that they were undocumented, that there was no visa that they were currently covered by, and that they didn't have any health insurance or Medicare. On questioning, they disclosed that they were working for a cousin in cleaning services. So again, just pulling out a few different scenarios that would concern me. Through the lens of modern slavery. Obviously, it's always difficult communicating with someone that has a language barrier, but that may also be intimidated by a situation of abuse that they're in. But the fact that they had no visa, had no access to Medicare, and had limited access to medical treatment for quite some time were really concerning, and they were referred to social work. Another few little quick ones, because I know we're pressed for time. There was a situation in a community clinic in a regional area in New South Wales where someone presented with abdominal pain that was sort of kind of had represented a few times and had a past medical history of alcohol use. So there was a little bit of unfortunate conversation that went in the tea room about, oh, this is just someone that's an alcoholic that's presenting with alcohol use. But some of the interesting things that I guess flagged some indicators for me was that they worked on a farm, and that they said that they presented very traumatized. They were sort of barely audible when they were speaking. They were kind of cowering on the bed and flinching when people moved around them. And on questioning them, they said, that they worked on a farm, but they weren't often free to leave when they wanted to, and they didn't feel safe there. So again, some red flags there. And the last one is just something completely different. This was actually someone that came into work with us as an agency staff nurse. So as many of our hospitals sometimes have staffing shortages, we sometimes hire external agency staff. this person befriended some of the nurses, seemed quite isolated and lonely, and struck up a friendship with a couple of us. And there was some attempts to try and catch up for coffee or something, and it became clear that every time we'd made plans, that those plans had to be cancelled because she was constantly being called in to do incredibly long hours and double shifts on really short notice. And she said that she could never say no because the agency that she was working with was sponsoring her visa. So there seemed to be some stress around that for her. So those are just a few little examples just to kind of start the thinking about, how some of these things might present, and there'll be some more information about, what indicators might mean and what to do about them. But yeah, I just wanted to give us a little snapshot of what we might see in our settings that might be like, oh, actually, I do think I've seen something similar, and maybe this issue does present in our hospitals. In terms of the impact on people's health, there's an abundance of research that shows that experiences of abuse have significant, long-lasting impacts on a person's physical, mental, and social health. And I think all of us in healthcare are very aware of this. When someone experiences modern slavery, they're usually subjected to a wide range of abuses, which may include sexual, physical, psychological, social, financial, and developmental trauma over prolonged periods of time. And I think that's the really important part, to realize that these people are not just experiencing these things once, but rather over and over again in situations of entrapment. Each part of that really long statement is important, because I think if you calculate the impact of innumerable assaults, you really see how that might annihilate someone's functional autonomy socially, financially, and over years in many cases. We know from studies of complex trauma that the element of entrapment itself amplifies the destructive potential of trauma immensely. We also have research that shows that this kind of complex trauma has catastrophic impacts on people's health and well-being, and places a tremendous burden on our healthcare in responding to these long-term health complications. We see that people in these situations often have much higher rates of mental health conditions, autoimmune disorders, chronic pain, cardiovascular disease, gastrointestinal disorders, and higher burdens of chronic health conditions such as cardiovascular disease and substance use disorders, diabetes and cancer. There are many, many different types of sort of chronic impacts that we see for this population group. If we look at even just one type of modern slavery, forced labor, for example, there's growing literature that shows that people in these situations suffer from impacts of occupational hazards and poor working conditions, including injuries and illnesses related to exposure to those conditions. And we consider the children that are sexually exploited, and whether that's online or in person, and how well documented it is that there are direct links between childhood abuse and poor health outcomes long term. We know as well that all of these things affect not only the person, but have continued intergenerational impacts within families and their communities. So that leads us to trying to understand what is the impact on our healthcare system. More broadly, obviously beyond the individuals affected around the world, slavery has had intergenerational impacts and across people. We have obviously a very complex healthcare system that is reliant on state and federal funding. Here in New South Wales, modern slavery also has those same impacts on the healthcare system. If we take the estimated New South Wales caseload and apply a methodology used by the UK Home Office, for example, it's estimated that the economic and social cost of a single case of modern slavery could potentially reach a staggering $8.5 billion in lifetime healthcare costs. These costs come in form of emergency department visits, untreated chronic illnesses, and the knock-on effects of drug and alcohol dependence or other complex trauma, which is why we think that it is so important to fight modern slavery, and that is a real health issue.
Thank you so much, Sarah. We really greatly appreciate your insights and the passion you're bringing to this. Just one small clarification. The $8.5 billion lifetime healthcare costs is for the full caseload in New South Wales, 16,400 rather than a single case, fortunately, but still a very, very significant number when you think about it. Now that we've heard from Sarah about how to characterise the problem, we're going to come to the question that's probably on your mind. Well, what can we in New South Wales, and particularly in the healthcare sector, do about this? The very short answer, before I introduce Amanda and Honey, is you can refer the matter to us for assistance and support. So of the 16,400 or so cases estimated in New South Wales, we currently only get about 100 formal reports a year through the formal reporting channel, which is the Australian Federal Police. There are other reports outside that system, but it's a tiny percentage, as you can see. And one of the key reasons for that is that people are very fearful to report. They fear retaliation. Their agency has been seriously eroded through the processes that Sarah's just described in such tragic detail. It's important for actors that have authority but provide a safe space for reporting to offer a pathway for people to disclose. My agency is an independent statutory office, has access to the governmental agencies, but we're one removed from that. Just 2 weeks ago, for example, we had a report from one of the big public hospitals in Sydney, and within 24 hours, we'd been able to refer someone who it turned out had been in trafficking for 20 years into appropriate crisis accommodation and wraparound welfare and support services. Healthcare systems are a critical place for people to disclose, but they have to be built and equipped and oriented the right way to understand what that will take and the kinds of safety and trauma-informed response that will be needed. And so I'm absolutely thrilled that we're joined this morning or this evening their time on the East Coast of the US by Dr. Amanda Stilianu and Dr. Honey Stocklosa from HEAL Trafficking. Dr. Stilianu is an international leader in healthcare responses to modern slavery. As CEO of HEAL Trafficking, she leads the organization's development of evidence-based, trauma-informed, and survivor-centered health responses to modern slavery. She's a licensed clinical social worker and has worked with survivors of violence, providing mental health counseling and case management services. Dr. Stocklosa, who I had the great pleasure of meeting many years ago when I lived in the US, is an emergency physician at Brigham and Women's Hospital with appointments at Harvard Medical School and the Harvard Humanitarian Initiative. She's an internationally recognized expert, advocate, researcher, and speaker on the well-being of trafficking survivors in the US and internationally through a public health lens. She has advised United Nations organizations and the US government on issues of human trafficking and conducted research in more than 10 countries. Her book, Human Trafficking is a Public Health Issue, a Paradigm Expansion in the United States, is, I can assure you, a cracking read. And it's the first textbook looking at human trafficking through a public health lens. So thank you, Amanda and Honey. Fabulous to have you with us. Over to both of you.
So good morning, everyone. Hi, I'm Dr. Honey Stocklosa. Thank you for that introduction, James. And I just want to open up by saying that this work is a calling for me as a medical doctor, as an emergency physician on the front lines. That's how I first came face to face with modern slavery, and I haven't looked back. And I'm really excited to see where this work takes all of you. So a little bit about what HEAL does. So HEAL has been leading the fight against modern slavery from a healthcare perspective for over 10 years. We've done that in a number of different ways, and our network has now grown to over 4,000 individuals in over 50 countries around the globe. To us, a public health approach is critical to this work. We believe that public health is the lens that allows us to be both proactive and forward-facing in a way that involves prevention, as well as reintegration, as well as helping survivors prevent re-exploitation. It's that all-encompassing approach that looks not only at the individual level to how do we prevent trafficking and intervene on trafficking, but what are the elements within our structures and communities to prevent trafficking from happening in the first place. So this statistic is quite stark. In New South Wales, it's estimated that 80 to 90% of modern slavery cases are not reported. I just want you to kind of take that in. I know James had mentioned some of the reporting mechanisms that are in place, and I want you to think about why that might be. Some of them were mentioned in some of the case examples that we heard from the top. What we know is that from New South Wales, and I've seen this really across the globe, the various barriers that survivors of modern slavery, while they're in the situation of exploitation, prevent them from feeling safe in reporting in many different ways, shapes, and forms. And a public health approach really takes into account what that individual survivor perspective is. And I'm not going to highlight all of these things here, but I just wanted to underscore a couple of them, including fear of retaliation, as well as lack of trust in authorities. I've seen this so many times in survivors that I work with in terms of fear of retaliation. While it may be fear of some ill to come to themselves, one of the things that keeps survivors of modern slavery in unthinkable situations is a fear of repercussions to their family. One survivor said, what a mother wouldn't do for her child, right? We can all relate to that. But recognizing that all of these methods and all of these barriers are also the same things that traffickers use to keep people in situations of exploitation. And then as we think about lack of trust in authorities, many victims of modern slavery may have had a prior experience with law enforcement. And again, that voice of the trafficker in the back of their head may be telling them that if they report to law enforcement authorities, it may lead to their arrest or deportation. Whether or not that is even true, it's a strong voice that they may hear in their head. So that brings us to the role of healthcare and the really powerful role that HEAL believes healthcare can take. And I hope that after today, all of you will be convinced of that fact. First of all, we know that over 68% of modern slavery survivors, those experiencing modern slavery, have contact with healthcare while they're experiencing that exploitation. And to us, that represents a huge opportunity as well as responsibility for healthcare to be prepared. At HEAL, we believe that a multi-pronged approach is really crucial and necessary in this work. No one sort of legs of these stools or ingredients in this puzzle is sufficient in creating the change within healthcare that needs to happen to truly make a difference for trafficking survivors. So some of these tools include education, skills building, foundational tools that can be replicated, protocols and policies, as well as data and quality improvement efforts. So I wanted to give some promising examples to help inspire you as we move from understanding the problem into thinking about action steps. In 2023, HEAL published, along with the World Health Organization, this summative report that was really kind of like a satellite view or a global perspective on the state of healthcare response to trafficking. And I want to underline a couple of findings from the report. One is that multi-sectoral coordinated systems and care have been shown to improve trafficking responses. So we know that when you put those foundations in place for response, that improves the lives of modern slavery survivors. And research shows that systems with modern slavery specific policies provide better care. These may not feel like rocket science, but they really underscore the fact that we need to be taking that multi-pronged approach and working from all angles synergistically and in concert. And just to highlight some of these components of national responses, regional responses that we see from that HEAL satellite view lens. From the UK, this amazing standards of care guide that was developed by practitioners. The PAIR tool, which stands for Privacy, Educate, Ask, Respect, and Respond, which is a structured conversation guide for health professionals. And finally, HEAL's toolkit adaptation in Brazil, in SUS, which is the public health system that is countrywide in the country of Brazil. So these are just snapshots. Many of these tools are scalable and replicable, and also to flag and inspire you that you're not starting from scratch. There are many shoulders to stand upon and some amazing efforts that can help to inform and form the foundation for the work that you're doing in New South Wales. Finally, the HEAL approach centers the voices of survivors, and we applaud your work to do the same. This is the why behind everything we do. And moreover, the wisdom that comes from survivor-centered approaches is a key to success in this work. HEAL believes that healthcare in New South Wales has an amazing opportunity to respond to modern slavery and are really excited to see the impact you have on survivors. Thank you so much.
You know, as we talk about at HEAL, when we start to use a public health approach to address modern slavery, right, we're now able to utilize a holistic strategy that addresses individual, relationship, community, and societal risk factors. And so as we sit here this morning and think about how we can begin to shift our practice and shift our practices and policies at system levels, right, we want to make sure that we're really focusing on this holistic strategy at multiple levels of intervention. So first and foremost, at the individual level, right, we understand that victims of modern slavery endure unimaginable suffering, facing physical, psychological, and emotional trauma. And so our approach must emphasize the importance of providing comprehensive healthcare services tailored to each survivor's unique needs, including medical treatment, mental health treatment, and social services to facilitate their recovery and reintegration into society. As we move beyond the individual, we want to focus on the critical role that relationships play in perpetuating modern slavery. When Dr. Stocklosa spoke some to the barriers to reporting, we know that victims often find themselves trapped in exploitive situations. There are power imbalances, coercion, and manipulation that's being used by the trafficker. And so when we foster strong community networks and promote awareness and education, we can empower individuals to recognize signs of exploitation and support themselves and others to accessing support. Right. Furthermore, we understand that modern slavery is not an isolated problem, but a complex social issue deeply rooted in systemic inequities, poverty, and social injustice. And so our approach must involve working collaboratively with communities to address underlying risk factors that make individuals and communities vulnerable to exploitation. And finally, and why we're all here today, is healthcare has a crucial and leading role to play in combating modern slavery. Healthcare providers, as Dr. Stocklosa highlighted, are often the first point and sometimes the only point of contact for victims, making them uniquely positioned to identify signs of exploitation and provide support and assistance. And so our approach to modern slavery as a public health issue is grounded in recognizing that we must take a multidimensional response that addresses the individual, relationship, community, and societal factors driving this injustice. And we believe that we can work together to end modern slavery and build a future where all individuals are free to live with dignity and respect. And so it's an honor to be here with all of you this morning as we begin building this momentum to creating system-level responses to modern slavery. And I have no doubt that in years to come, New South Wales has both the excellence and capacity to be a global leader in this work. So thank you very much, James.
Thank you very much, Dr. Stilianou. And I think we will greatly benefit, we are already from your interventions today, from having you and Dr. Stocklosa, who are established global leaders in this field. Part of my role under the Modern Slavery Act 2018 of New South Wales is to promote good practice, encourage training and so on in this area. And we think that in doing that, we don't need to reinvent wheels. There is good practice emerging internationally, as we've just seen, that we can learn from, that we can borrow from and build on. At the same time, we also need to build on the capabilities that are developing here in New South Wales and Australia more broadly. So I'm thrilled now to introduce Dr. Jamie Burrows to speak to us about the role that New South Wales healthcare practitioners can play in addressing modern slavery. Dr. Burrows is an emergency physician who's been specialising in emergency medicine here in New South Wales for the last 10 years. Originally from Ireland, Jamie graduated from the University of Sheffield and worked in the NHS for a couple of years before moving to Australia. It's in Sheffield as an intern, where her interest in the intersection of modern slavery and healthcare began. Jamie's since been studying the evidence around the topic, undertaking further studies in public health at the University of Wollongong and completing a research year with the Green Light Institute for Emergency Care. Jamie's been awarded a modern slavery research grant from the Commonwealth Attorney General's Department, and so over the coming months we'll be focusing her efforts on undertaking a usability study for modern slavery screening, providing regular education to healthcare groups and engaging survivors in formal consultation. Welcome, Dr. Burrows.
Thank you, James. So when I tell people and my fellow colleagues in New South Wales that I do anti-slavery work, I would say that the majority, maybe 99% of the reactions I get fall into two categories. One is, oh, does that even happen in Australia? Is that even a thing here? And the second one will come from the more reflective practitioners that will go, oh yeah, I think I saw one patient in my career that I thought was in a situation of trafficking and slavery, and almost always that will be a young female in a horrendous sexual exploitation scenario. So it'll be good today if at the very least we can go away and realise that yes, this does happen in Australia and in New South Wales. But it's also in not only the first patient that you think of. I like to show this slide. I did a presentation to emergency doctors and nurses and allied health professionals. They didn't know what I was presenting. And I started by giving some cases. So very much like the cases that Sarah shared with you, a variety of presentations, a variety of ages. So a female with suicidal ideation and sexual assault, a young man with a burn from a restaurant, an older man with poorly controlled asthma, a nursing student with chronic headaches, and a representation with back pain. Lots of different scenarios that had a little twist. And I asked everyone to write in the piece of paper what they thought brought these patients together, or what was the common theme, and to share it with me. Now, as you can see, there's a lot of different answers there. We've got people, you know, that identified that all the patients were discharged, that there was an undifferentiated diagnosis. Then there's words like communication issue, vulnerability, anxiety, domestic violence, intimate partner violence, abuse. And we had a very keen triage nurse that even identified that the patient should be category 3. But I suppose what we didn't see was, or what we didn't see people thinking about, was modern slavery or slavery-like practices. And it's very clear that this isn't in our vocabulary just yet. So I'm really looking forward to the day when us as health professionals see these patients, and instead of just saying, oh, there's some form of abuse there, maybe we'll think a little bit further and think, is there a slavery-like practice, or does this come under the umbrella of modern slavery? So as Hanny and Amanda pointed out, there are risk factors for this. And as Sarah pointed out as well, you know, there are risks that we need to look for and indicators. Now, in New South Wales, globally, we see most of the types of slavery happening in most of the countries. However, there will be certain things in New South Wales and Australia that we should be keeping our eye out for a little bit more. For sure, socially and economically disadvantaged communities are at increased risk. And we, no matter where you work in New South Wales, you know, we provide care disproportionately to the most marginalised of populations. There are lots of risk factors there which have been touched on already. I work in RPA, Bankstown hospitals, and more recently Northern Beaches hospitals, very different patient demographics, but you can be sure that there is modern slavery within those populations. Someone said to me the other day, oh, I'm sure I see it in this place I work, but probably not in the other place. I suppose I challenge you to realise that wherever we have services or labour, it will be occurring. So around RPA, we have a high, you know, lots of international students, for instance, and we know that insecure visa status and temporary visa holders are at risk of exploitation. And I think in Australia, there's about 1.6 million temporary visa holders. In Bankstown, just recently, I met a patient that had managed to escape a situation of forced marriage, and I suppose in that area there might be risks of that. That is the most reported form of modern slavery in Australia. And up in the northern beaches, you may think that doesn't happen there, but of course you have hospitality, you have hotels, you have construction happening, and we've seen that in the most affluent areas in Australia, there is cases of domestic workers. So I think we need to challenge ourselves that some scenarios and some corners of the health service, it is more obvious where it is, but it's certainly in more places than we think. So I don't have time to go through the indicators, but we've got the risk factors, and there's some great tools with Heal Trafficking and Watch This Space, and what we will create to share educational opportunities and also collaborate with you all to really build the capacity in health professionals to identify the indicators. Sarah went through a couple of them in her cases, but I suppose then you go, well, I've thought about the risk factors, I've identified some indicators, how do we respond to it? We are at the beginning of really tailoring our healthcare response in New South Wales, and it's an exciting place for everyone to come on board at this point. I suppose I'd echo what Hanny and Amanda said, is that there is a lot of work already done, and I've just included a few organisations there for illustration more than anything, that people have been working in the community with this over years. So it'll be really exciting for us all to come together and streamline those referral pathways. But in the meantime, while we're organising all of that, I suppose there's just a few really critical things that we can do as individuals and within your departments. Trauma-informed care, of course, underpins and is the most important aspect of how we approach this with our patients, listen to our patients and our survivors. And even if this is something you've never heard of, I wouldn't be daunted by it. I think some people go, oh, I've never heard of that. How do I respond to that? We're actually already providing care to people in going through horrendous exploitative situations with serious medical and social and mental health issues. So you're already doing the good work in it, and we don't need to reinvent the wheel. I think this for sure, hopefully we have pointed out why we need to make a very tailored response to this, and modern slavery in itself deserves a response in itself. But there's teams with mental health and pediatrics and justice health, refugee health, the Indigenous health. There's so much already being done, and we'll definitely be able to share our processes going forward. Hopefully we will, like we say, have a very tailored referral process and things for you to reach out to. But for the moment, a lot of these resources and these communities and these organisations are really willing to help. So look at the website, look at the numbers, and everyone's on board to try and respond to these patients. Even if we get the the risks, the indicators, and we do trauma-informed care well, I think one of the most important things that you can do for the moment is providing a safe place for patients to return. Because you can be sure, even if we do everything right, a high proportion of patients, due to complex trauma and a lot of other reasons, will refuse our care. I just wanted to finish on this last point for everyone to take away, because I find if I've done presentations before or webinars, my colleagues will come to me and say, I thought about what you said. I think this patient is in this situation. We've offered this, this, and this, but they want to go home or they're refusing our care. What can I do anyway? That can be disheartening. But I think for some people that work in New South Wales Health, you'll recognise this form. This is a discharge against medical advice form. For some, you may never have seen it. I think in these scenarios, when we're dealing with patients that refuse our care, I think it's very easy to say, oh, well, I've explained the risks. They can make their own choices, sign this form and leave. So I created a little acronym and I suppose a tool for healthcare professionals to take away. And if anything, as you go forward with starting to see patients in exploitative situations or patients you suspect to be in modern slavery that want to leave, and I would challenge you in the 5 minutes that you have with that patient. It's such an important intersection that we have. Even it's not about rescue or reporting necessarily, it's about how you can use that 5-10 minutes and that quick interaction in a positive way. So this is a SCARED acronym. Not only are the letters quite good, and that's why I used it, I suppose it's a reminder that a lot of these patients will be fearful, and that will inform a lot of their choices. So safety, first of all, it's always a priority. And again, don't get bogged down with thinking that this is something different. All the usual safety parameters that we use for our patients and our mandatory reporting guidelines apply for these patients as well. Once you've clarified the safety, then confidentiality, it's one of the most important things that we can offer to the patients. Obviously, we can't provide that 100%. Again, the New South Wales Privacy Manual applies. There's nothing different about patients in situations of modern slavery. But I find it really important to, I suppose, provide that confidentiality and verbalise that you're providing it. You'll get your own patter. I usually say, your confidentiality is really important to me. Sometimes it's enough to disarm the patient, or sometimes it's just important to make them feel safe. The next 3 things I don't think we do all the time, and I think it's a really valuable tool in those 5-10 minutes. Autonomy for a patient, where their choices have been taken away from them every single day. Not only should we respect their choices in every regard with the healthcare that we're providing, try your best to provide choice wherever you can during that consultation. So I do it in little ways. Would you like the curtain open and closed? Would you like the door open and closed? Is it okay if we talk now, or should I come back? Whatever it is, those little nuggets of choice that we can give back to patients can go a long way. Also, rights. So sometimes patients, and Sarah touched on this, sometimes patients aren't actually aware that what they're going through or that is wrong, or that their rights have been taken away from them. So something simple like just reminding the patients of the rights. It's your right to have access to safe working equipment, helmets. Do you know that you should be having breaks? Or it's your right to be allowed to leave the house when you want, or have toilet breaks, or be able to see your children, or have access to your ID documents. Whatever it is, a little reminder. And then empower the patient. This can be through, sharing positive examples, like, we see patients in your situation and we have teams that can help you. We have helped patients before, whatever it might be. And then deliver something, and don't just deliver a signed discharge against medical advice form. Social work consultation, of course, that is gold. If that is accepted, brilliant. But a short stay admission, a leaflet, a website, a helpline number. And I think most importantly, if we can't deliver something tangible like that, moving forward with improving healthcare utilisation with these patients, no matter how fractured your consultation might be, try your best to deliver a safe place for these patients to return to.
Thank you so much, Dr. Burrows, for really bringing us back to earth and showing us what this work has to look like in that immediate human-to-human contact and clinical setting, but also for emphasising, as you did, that there's already a lot of great work going on in this area. In a short webinar, we can't highlight all of that, but I do want to acknowledge you and others on the call, for example, from St Vincent's Health Australia, Australian Catholic Anti-Slavery Network, ACRATH, and others who've been doing fantastic work in this area and really been at the forefront of the effort to bring a public health perspective into our work. So it's a privilege for us at the Office of the Anti-Slavery Commissioner to help build on that work and connect things up, connect it to international practice, and support it moving forward. And that's what we're going to come on and talk about now. It's now time to talk about how you can get involved in this work here in New South Wales. And for this, I'm going to welcome back Sarah and also introduce Corinne Baker, who's leading the It's Healthy to Fight Modern Slavery project for our office. So Corinne is another of these unicorns with multiple areas of expertise. She has more than 15 years experience in the health and humanitarian sectors, including several years working with New South Wales Health in public and population health teams at both the Ministry of Health and Southeastern Sydney Local Health District. Prior to that, she spent more than a decade working with Médecins Sans Frontières, also known as Doctors Without Borders, supporting healthcare projects across sub-Saharan Africa, South Asia, and Eastern Europe for people experiencing conflict, displacement, disease outbreaks, and natural disasters. So incredibly well positioned to bring that wealth of experience to this complex area of both individual medicine and public health response. So over to you, Corinne and Sarah.
Thanks very much, James. So as we've heard from all of our speakers today, healthcare workers and the New South Wales healthcare system more broadly have a really crucial role to play in identifying and assisting people at risk of or experiencing modern slavery. So that's why one of the first priorities of the Commissioner and our team has been to develop this project. It's Healthy to Fight Modern Slavery. The project directly goes to addressing the first priority in the Commissioner's strategic plan for 2023 to 2026, which is to build prevention capacity across New South Wales government and non-government systems. So what is it? It's Healthy to Fight Modern Slavery. So it's a project that will, for the first time, bring together health professionals from across the New South Wales healthcare system with experts from the anti-slavery sector in what we're calling a multidisciplinary community of purpose. You might also like to think of it as a network. So this community of purpose will work together to help equip healthcare workers across New South Wales with what they need to be able to identify vulnerability to modern slavery in the first instance, prevent victimisation, and support survivors in their recovery. And as highlighted earlier by Amanda and Hani from Heal Trafficking, people with lived experience of modern slavery will very much be at the centre of our community's work, which means that there'll be a focus on developing trauma-informed and culturally appropriate tools, protocols, and practices.
So one of the things that we wanted to answer for people is, what will this community of purpose actually focus on, in much of the same spirit as the approach outlined by Dr. Stocklosa from HEAL, where they have the different pronged approach. We've identified 5 different areas that we believe are key if we're actually going to make some progress on this issue here in New South Wales. The work of this community of purpose will be framed around these 5 areas. The first one is awareness raising and education. We believe that from most, obviously, as we've said prior, most clinicians have mentioned that they're not necessarily aware of modern slavery or how it's a problem here, and people are under the impression that there is sort of an overseas component to this, that it's not really part of our medical education, and have no real idea about how to respond to it if they do see it. And I think, given that also many of the survivors are not aware of the situation they're in, makes it doubly difficult, because they may not even be able to self-identify and tell healthcare professional what's going on for them. Secondly, we want to work on developing some tools and protocols to help identify, and there's some work going on from various projects that have been funded by the federal government. And one of the reasons we kind of wanted to bring this community of purpose together is that, you know, we could all work on all of these different things and all be doing the exact same thing, but how much more effective might we be if we bring all of those amazing minds together to really come up with something that's practical and that actually can be fit for purpose and used in our healthcare settings. Thirdly, the third area that we've identified is our referral pathways. Jamie alluded to this earlier. I think many people say to me in healthcare, well, if I do identify someone, what do I actually do? I have nowhere to send them. And it's true, like when someone comes in with chest pain, we know exactly what to do. We'll send them to the cath lab if that's necessary. If someone's in a situation of domestic violence or sexual assault, thanks to many years of advocacy and hard work, we now have referral pathways and protocols for these kinds of situations. But unfortunately, services for survivors of modern slavery are still really fragmented, and we need to map and create better referral pathways. I guess, you know, in I think in public hospitals now, we're starting to see people starting to recognise these things, refer things to professionals that they might be aware are working on this issue. We had a situation like that in Melbourne recently, but also, the Commissioner mentioned a situation in which someone was referred and we were able to respond, but we know that more work needs to be done to create better and more effective referral pathways. The fourth one is data collection. A lot of the data that we've mentioned today is data that we have used from overseas, because we just don't have similar research base to draw on here in Australia around this issue. So we know that data collection and understanding the demographic and how people are being affected by these things is important if we are going to address it effectively. And fifth, it leads us to the final piece of our puzzle, is that research and evidence base and how we build that along with the data that we can effectively collect. So I think these were the 5 areas that, in consultation with different clinicians and experts, including HEAL, we identified as a way forward in New South Wales if we are going to make a real difference in addressing this in our healthcare system. We've also don't see this as something that happens in isolation. I don't think we can separate all of these different aspects of our approaches. So we've conceptualized this more as a wheel of system change, and each part sort of feeds into another. Some people may already be engaged in work that covers one or more of these areas, and we really hope that this community of purpose will bring together healthcare actors that might be able to contribute to the areas of work that might fit with what they're already doing, or something that they may be interested in contributing to, and then sort of slowly build that longer term process of system change.
So who are we looking for to be part of this community of purpose? So as I mentioned, we're aiming to build a multidisciplinary network of people from across both the healthcare and anti-slavery sectors, who are interested in and can contribute to this work in one or more of the 5 areas that Sarah has just outlined. And we're looking for people at both the frontline service provider level, policymakers, and as well as the management and executive levels to be part of the work. So you might work in emergency, you'll be involved in education and training, developing health policy and programs for vulnerable communities. You might be a social worker in a healthcare setting. You might actually have insights to share from your experiences driving change on connected issues such as domestic and family violence or sexual assault. Or you might be a service provider who can be part of a referral pathway for people who need assistance. Even if you're not quite sure yet where you might fit into the puzzle, we're really happy to hear from you. So the role of our office in all of this, will act as a convener for the community of purpose. Will help facilitate access to international best practice, such as through the support of field trafficking, and will also help facilitate the safe inclusion of expertise from people with lived experience of modern slavery in the development of tools, protocols, and research. So we'll be a facilitator, but there will be plenty of space and opportunities for members of the community of purpose to shape the initiative as we go along. So in terms of opportunities to get involved, on the next slide, we'll share a QR code that will take you to a form where you can express your interest in being part of the initiative. You'll also, in that form, be able to indicate which areas of interest and expertise you have, and in what ways you'd like to engage with this work. Our team will then be in touch if there are relevant opportunities for you to be involved this year. And then over the course of the rest of this year, we'll have several opportunities, such as online through working group meetings and in person at a 2-day workshop in September. So I'll give you a moment to scan the QR code and go to the form. We'll share the link to the form along with a recording of the webinar after this to everyone who registered through the event page, and you're very welcome to share it through your networks as well. While you're doing that, I'll say a few brief words about the workshop in September to give you a bit of a sense of what will be involved in that. We'll be very lucky to have Amanda and Hani from Heal Trafficking, who'll be making the trip over from the US to Sydney for a 2-day workshop in person. And we'll be working with some members of the community of purpose in the working groups in the months leading up to the workshop, so we can co-design the agenda and make sure we have some really clear and practical outcomes that can then be taken forward by the broader community of purpose over the next year or so. Recognise that not everyone has sort of capacity to maybe actively participate over the coming months. We would still really love you to stay in touch with us. So if you're keen to keep in the loop about this work, please do complete the form and just tick the option on there that will ask for updates, to receive updates from us. And we will keep the form live past the 5th of April. As we know, these things can take a little bit of time to work their way through the healthcare system. We want to make sure people have the opportunity to be part of it.
Thank you so much, Corinne and Sarah. Very exciting, all of this work ahead, and fantastic to have such a range of inputs and insights from our speakers today. I invite all the speakers to come back on screen so that we can go through a few of the questions that we've received. What I'm particularly excited about in the upcoming initiative that you've just mapped out, Corinne, is the way that the different strands of engagement and thinking are going to connect to a conversation about system change. We have a system in New South Wales in responding to modern slavery that's relied heavily on criminal justice responses, and I don't think that that's I think that that may be connected to why we see relatively low reporting rates. So part of our goal here is about equipping different parts of governmental systems to provide different reporting pathways and different ways to deliver support and services and human rights to people living in New South Wales. Dr. Stylianou and Dr. Stocklosa, I'm going to come to you. You have been involved in this kind of transformative system change work in public health systems around this issue, specifically around modern slavery and human trafficking. I wondered if you might give us a couple of insights into or examples of some of the successes that you've seen in those kinds of transformations overseas, just as a bit of a teaser for people here in New South Wales about what that might look like for us in months and years ahead.
Yeah, I'm happy to share, and I thank you for the opportunity. I only got to talk in sort of small bits, some of the case examples that we highlighted, but you know, as we look to the UK, I think we have a great example of multi-pronged efforts that came together both on the systems level and the public health infrastructure delivery level to create policies, along with a constellation of champion practitioners that led educational and training efforts, and then led advocacy responses to continue, and they continue to create that lasting continuity change kind of work that's necessary. As Sarah mentioned, this is not something that happens overnight and requires that long-term tenacity. So UK is one example that comes to mind, and then most recently in Brazil, HEAL has had the privilege to work in one of the most vulnerable regions in the Northeast with health practitioners, along with community service providers that are doing anti-trafficking work, to develop a customized protocol for their health system that takes into account not only the trafficking victims or modern slavery victims that they're seeing and the characteristics and red flags that are unique to that region, but also the local political factors, the local response mechanisms that are in place, things that need to be changed, and things that we can really build on and amplify and magnify. So those are just two sort of top of mind examples. This work makes a difference. It's life-saving work. So I'm really excited to see where this takes all of us collectively.
Fabulous. Thank you so much. Dr. Stylianou, anything you'd like to highlight out of HEAL's experiences or your own?
You know, I think one of the things we have found is countries and locations that are most successful really look at not just how do we train our frontline staff and our practitioners, but how do we make this change sustainable and lasting? And so what are the policies and the practices and the support that is needed to really sustain this movement? And so I think, you know, as we're thinking about this work here in New South Wales, right, how do we think about kind of all the levels that we want to create change so that the system can maintain that change over time?
Fantastic. And obviously a key part of that is about evidence and data. And one of the questions we've had come in is about experiences there. It's obviously one of the strands of work we'll be looking at. We have a extremely fragmented data ecosystem when it comes to modern slavery in Australia. Some important efforts at the federal level, mainly around federal government agencies at this point, to integrate data. But in the healthcare system, no real collection of data on this cohort. So the question that's come in is whether you, again, to Dr. Stocklosa and Dr. Stiliano, whether you've seen examples of improved data collection overseas. Is there common coding that's been adopted, anything like that? And then Dr. Burrows, I'll come on from there to you to ask if you could share a little bit about your usability study. So back to you, Dr. Stocklosa and Dr. Stiliano.
Yeah, I feel like the common theme here is multi-pronged. So we need data from a lot of different angles. There's the kind of like almost acute needs, which, you know, are relatively straightforward studies that can be done sampling those with lived experience of modern slavery to ask that cohort what their experiences are with healthcare, both in terms of to get a, you know, a percentage that's similar to the global number that we shared, to see what that percentage is locally, and then ongoing, right? How do you have an ongoing system of data collection that captures both quantitative and qualitative experiences? On the quantitative side of things, there's different approaches that we've seen. You know, I go back to the United States in this example, but the ICD codes for human trafficking were implemented now over, it was pre-COVID, that's all I can tell you. It's been a number of years now, and that's been really helpful for us. It's one piece of data. It's not, because they are not being utilized as universally as we would like to see. It has its limitations, but it's also something that we can track over time. So I'm happy to talk in more detail and more nuance, but I think there are sort of the urgent questions that need to be answered that can help inform our responses. And then there's ongoing sort of maintenance and surveillance to help us continue to see how our work is being impactful, as well as to understand what the needs of trafficking survivors are in the long term.
Yeah, great. Dr. Stiliano, do you want to expand on this one?
Sure, and that, you know, I think this is probably your question of focusing kind of on data in terms of prevalence and needs of survivors. We also, of course, want to focus on collecting data and evidence on the interventions that we're developing. So the policies and the practices and the training. HEAL has done a tremendous amount of work with partners throughout the globe in developing and then testing different interventions. Everything from, you know, how do you train medical providers to identify and respond to trafficking, to what are the best policies and practices and quality improvement practices. So we very much look forward to the fall, or to our fall and your spring, when we can come out and share those in more detail as well.
Thank you so much. Just before I come to Dr. Burrows, just noting that there may have been a glitch on the form about email addresses, but there is now a field on the form. If you filled in the form and couldn't see where to fill in your email address, if you wouldn't mind just revisiting the form, fill in a new form, we can collect your email address from there. Alternatively, you can always contact us at antislavery@dcj.nsw.gov.au. Just once again, that's antislavery@dcj.nsw.gov.au. So, Dr. Burrows, when I introduced you, I mentioned that you're involved at the moment in a usability study that's funded by the federal government. I wonder if you might say a word more about that and how it connects to these broader questions of how we actually identify and support this cohort.
Yeah, I think the non-negotiable and the most important core way that we can start identifying patients is to build the clinical acumen for it, and that is, educating on the risks and the indicators, and that all needs to happen for sure, and that's something that will take time. And that's a non-negotiable. The other question is whether we should be screening for this, and there's a lot of pros and cons of a screening process for such an issue. Annie and Amanda will be well aware of the RAF tool, and McKinney I'm sure you've worked closely with McKinney before. There was the rapid appraisal for trafficking tool that was well validated in the US, a 4-question tool for use in emergency medicine settings. Now, there's something very exciting about that. It's a quick tool. We like rapid processes in emergency, but there's a lot of questions that we need to ask about screening in the ED. So we are doing a very small, it's just the start of a bigger picture, a usability study. It's got nothing to do with the tool itself. That's already been validated. And if ever we were going to screen for this in Australia, we'd need to give a lot of consideration to the types of questions we ask and whether we should be doing it at all. But what I'm interested in is, what does that process look like? There are so many barriers to doing any sort of process in such a busy environment. And to do this in such a trauma-informed way, you need space, you need time, you need privacy, dignity, you need, interpreters, social workers available, all of these things. And in a system that's already quite stressed, we need to ask ourselves, if we are to do a process like this, how can we maximize it? Or what are the barriers to that? So very small usability study. It's going to be an RPA in Bankstown Hospital to begin with. And we're hoping we will uncover issues to screening and inform any other emergency departments that would like to do any screening initiatives going forward. We'll hopefully be able to inform them on how you might be able to streamline it or improve the process. It may be by the end of this all that we realise that we shouldn't be screening for this at all, but it's a good first start into seeing how that would work in Australian emergency departments.
Thank you. Yes, and as you emphasised, Dr. Burrows, there are obviously specificities to the experience of modern slavery here, or experiences, I should really say, of modern slavery here in Australia. For example, the emphasis on forced marriage in our context compared to some North American contexts, which means we'll have to think carefully, and we need to develop an evidence base. So I hope that this initiative, It's Healthy to Fight Slavery, will provide you a venue for networking and to bring the results of your study in to talk with peers and other organisations about how we can build on what you've learned from that study. I'm going to come, we are just approaching time. I'm going to bring the last question, it seems appropriate, to Sarah. Sarah, there's a question from Kate Gebhardt in the Central Coast, I think it is, local health district, who says, how do individuals who are victims of modern slavery describe themselves? How do they feel about the term modern slavery? Ms. Gebhardt says that she's a social worker and looking for language to use with patients that feels right for them and is respectful. We might ask you, Sarah, if you have thoughts on that, and then we'll wrap up.
I think whenever I talk about this, and I've heard other survivors speak about this, the journey of identifying with the words modern slavery are just that. They are a real journey for people, and they may not be comfortable with those terms because words like slavery often carry a lot of shame and stigma with them. If someone had asked me straight out when I presented to those emergency departments, are you being trafficked? I would have said no, because my understanding of trafficking was so different than the reality actually is. So one of the things that I always encourage in the way that I often approach it is sometimes people will be more comfortable about answering questions about how they feel at work, whether they feel safe, whether they feel trapped, or whether they feel that they were tricked about the situation of work that they're in. And that, again, obviously centers around that universal definition of the use of force, fraud, or coercion to exploit someone for personal or financial gain. And usually if I ask someone how they felt, if someone had asked me, do you feel trapped in the situation that you're in? Do you feel you're forced to work for this person? And do you feel like you were tricked in how you got into the situation? I would have said yes to all of those questions, but I would have not been able to use the words modern slavery or even trafficking in or sexual servitude, as was the case, in the situation that I was in. So I think it's about walking that journey with people. Sometimes, it's about using that rights-based language, as Jamie sort of said. You have a right to feel safe at work. You have a right to make a choice about what you're doing at work and the freedom that you should have, supporting them with the knowledge that they need to kind of walk that journey for themselves. Because for many of us, that takes months to really come to terms with what it is that's happened to us, and we'll identify different ways. So I don't know if that answers the question.
That's terrific, Sarah. Thank you. And I think really is a great place for us to wrap up in the way that you've emphasised that the opportunity we have here with healthcare is around treating the human being, regardless of the category that they may fall into, or the whether there's a criminal offence involved. If we want to prevent modern slavery, we need to think about what the risks of modern slavery are, how they play out in individual patients' lives, and tackle those risks and help them find the remedies that they need to the harms that they're experiencing and suffering. So thank you, everybody, for the time you've spent with us today. Please do register your interest, or feel free to reach out to us via any of these means of communication. We really look forward to going on this journey with you over the next couple of years. And my biggest thanks in particular to our speakers today, to Dr. Stocklosa, Dr. Burrows, Dr. Stilianu, Sarah, Corinne. Special thanks to Corinne for all the effort that she and her colleagues have put into organising today's session. Thank you to Dr. McGurr also for joining us on a busy day. We look forward to continuing to work with all of you in the months and years ahead. Thank you very much. Hope to see you again soon.